Welcome, my dear students. The topic that I take today is challenging and of paramount importance. Be aware that renal pathology is not common pathology, and nephrology by itself is a super specialty. The backup that these biopsies have are of great significance. For example, without an immunofluorescence or earlier on an electron microscopy, the renal biopsies would have been meaningless. In today's class, I shall be dealing with the technical part of it, the procedure, and this will be followed by a more important, interesting, and an examination topic of interpretation. Both of these are of very great significance for the exam going postgraduates. So as usual, I'll be having a set of subheadings. Think of the subheadings. The subheadings will take you to the answer. We shall not waste a picture though. I have got a perinephric fat. There is a cortex and a medulla, the pyramid, and the calyces. What is an adequacy of a biopsy? Always one is of an opinion that if I take a 2 centimeter worm, it is adequate. But it was experience that enlightened me in PSG Medical College, where in those days, the nephrologists, they are very inquisitive about their own biopsies, their findings. And one such person came down to pathology lab and was very disappointed with his own biopsy because the glomeruli were not adequately represented. And then on, the biopsies were fantastic. Today, that is what we see. There has been a leap and bound improvement in renal biopsies. Again, the glomerulus is nothing but a tuft of capillaries. So I find that there is an afferent and an efferent or a venule, and these are all the capillaries and the capillary loops, which are obviously supported by mesangium, lying in an empty space called the urinary space or the Bowman space, surrounded by the Bowman's capsule. That much is enough for now. Or look at this. One should definitely appreciate such biopsies. And my dear students, kindly be aware that the endoscopist, the radiologist, and the renal pathologist or the nephrologist, they are all of great advance in techniques. And look at the yield that is over here. I'm seeing 1, 2, 3, 4, 5, 6, 7 glomeruli in this. And how can one say that it is not adequate? This is a slide about the histology. For anything, we should know a normal. In the kidney, there are certain things which are of great importance. They will help us to organize and then find a way for the diagnosis or the study. One is the glomerulus. 2, the tubules. 3, the blood vessels. 4, the interstitium. These are things that we should never ever forget. Glomerulus, tubules, blood vessels, interstitium. And at a higher magnification, it is simply amazing. I told you that the glomerulus is a tuft of capillaries. And when I say capillary, it is very peculiar in the kidney. It has got an endothelium like any other blood vessel, but then it has got an epithelium also. And both of these are supported by a basement membrane. So that is what I'm seeing over here. And the pink substance that I'm finding in between will be the mesangium or the mesangial matrix. This is the urinary space over here. And here also I am observing some blue structures, which are the parietal epithelial cells. So kindly be aware of it. So you have got an arteriole over here and a venule. This kind of concept you people should have. Kidney is a little difficult. It used to be challenging, and I used to be one of the forerunners in the taking of the renal pathology. Be clear. Again, all the elements are given over here. Be very patient and try to identify them. Describe them. After all, what is urine? Urine is an ultrafiltrate of the plasma. And what is plasma? It is blood. And where does the blood come from? It is from the capillaries. So without knowing this, there is no point in reading the renal pathology. So structures. The glomerulus, the Bowman's capsule, the space, and the proximal convoluted tubule. Renal biopsy is not that new. It is almost now a century, I would say. Alwell in Sweden, 1944. Brunn and Everson, 1951. Kark and Murch, I do not know the name, 1954. And there has been a SIBA Foundation for Kidney Biopsy. There are many other names which will indicate the advances in renal biopsies and the procedures. This I shall come to later, but then even after a biopsy, it is supposed to be inspected under a hand lens or a dissecting microscope. Now, what are the indications for a renal biopsy? I always used to say subheadings, 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 indications. Whenever there is an unexplained acute renal failure, rapidly progressive renal failure or disease, nephrotic syndrome, non-nephrotic proteinuria. There are lots of causes of this which you people will know or will be knowing. Persistent glomerular hematuria. Glomerulus, again and again they harp on the word glomerulus. Systemic diseases with renal involvement. For example, amyloidosis. Renal allograft dysfunction. This is of great importance. The patient will be on the table or would have just entered the ward, and you will have to give an opinion on the graft acceptance or the rejection. And look at the technique over here, the composure of the nephrologist and the ultrasound being over here as concentration is both here as well as on the picture as such, and the patient is lying in a supine position, and preferably from the patient's left side, the biopsy is being taken. A little picture is worth a million words. Having said the indications, what are the contraindications? There can be absolute contraindications where we should not do the biopsy. Small kidneys. What is it? I shall be showing. Abnormal coagulopathy. After all, your needle is going to puncture many a capillary and there is going to be devastating bleeding. Uncontrolled hypertension. Relative contraindications of solitary kidney. Try to preserve it as much as possible. Do not make it malfunction. Uncooperative patient, you and I cannot do anything. Unable to lie on a flat bed. So these are relative contraindications. Probably the nephrologist will be having some kind of a solution for it. And in this, it is a case of a hypoplastic, a small kidney on the left side, diagnosed by ultrasound. What is the technique over here? This is another picture. Again, you find that it is being guided through the ultrasound and the biopsy is being done. The patient is in the prone position, lower pole of the left kidney. This is mainly intended to avoid injury to the nerve or the blood vessels. In the case of obese patients, supine position anterolateral. So SALP. Supine position anterolateral can be done. Less breathing difficulty. And there won't be any reduction in the yield in such patients. And this is again something that we people should know. I always used to tell my students, always when there is a needle, there is something inside called the stellate. These needles have got a sharp cutting edge. It is not a tip, it is a cutting edge. And it cuts through the tissues. And in order to avoid it damaging all the tissues in between by its shearing force, there is something called a stellate. So this is a stellate over here. A stellate is over here. And strangely, it has got a bifurcating tip. So the moment a biopsy is done, you find that the tissue is caught in between the tips. Also, you find that there are provisions for, say, a guide, and sometimes a camera might be attached or so, whatever it is, and a biopsy can be taken through this space. So this is the Silverman needle biopsy needle, renal biopsy needle. And the importance of the kidney, uniformly different. So look at this, you people will be able to observe it yourself. The glomerulus we had already spoken, we will not go to it. But these are all the tubules. Find out there is a lining epithelium like this, there is another lining epithelium, and this is more flattened and bent, distended, so on. So there is different morphology of the tubules based on whether it is a proximal, a distal, or a convoluted, or a loop of Henle. And this will be the interstitium. Generally, there will be a back-to-back arrangement of the tubules, but then there can be an interstitial widening in edema, there can be a fibrosis, there can be an inflammatory infiltrate, which will be altering the morphology. And look at this over here. So this is of great importance. Incidentally, students, I would like you people to kindly apply it in the difference between the adult and the infantile cystic kidneys, polycystic kidney. You find that there will be the difference in the lining epithelium. So the needle that has been used. One is the Wim Silverman, the other is a true cut, which is manually operated and sheathed or covered. Sometimes they are automated, spring-loaded biopsy guns. So you find that he is applying some kind of a pressure, there is a spring, and there is a withdrawal wherein the tissue is brought into the needle. And generally it is said that guided aspirations or biopsies are better than blind. And bleeding can be minimized in this. And this is the reference for this beautiful set of pictures. I would like to appreciate them, thank them, and also guide you people to them. And look at this over here. They are not just taking a single strand, and they are taking 3 or 4 strands of these biopsy tissues, whatever be the millimeters they are in. And also there are some arrows, and there are some areas over here. I hope you people can identify the areas of congestion. I do not know whether I am correct. Correct me if I am wrong, we'll see it in the subsequent slides. And we as pathologists and as students, we should be familiar with the process, the fixatives, the containers, the labeling of the containers, the request form of very great importance, clinical details, and transport. So biopsy, what is the advantage of a guided biopsy? The ultrasound guided automated biopsy guns, there is a very high success rate, very low failure rate. This author puts it down as 0.3%. Complications are about 5 to 7%. Surgical intervention might be needed only in 0.8% of the cases. The CT guided in high risk and obese patients can be of importance instead of just the ultrasound. And there is something called as fluoroscopic imaging, an ability to visualize the kidney during and after the biopsy. These are of great importance. Probably the CT will help us in this. So what is the ultrasound guided? What is the CT guided? What is the CT fluoroscopic imaging? And then what is the imaging before and after the biopsy? Again, the same old story, the position, etc. You people can narrate. Laparoscopic biopsy. It is a continuation of the previous one. This particular chart, I would like you to buy. So there is something called as a laparoscopic biopsy. There is no comparison between the three columns. Laparoscopic biopsy, solitary kidney and obesity, there can be contraindications. They can be done under direct microscopic vision. Open or incisional biopsy, laparoscopic biopsy is a replacement for ultrasound guided. And a better biopsy will be a better homeostasis and hemostasis probably. What are the indications for laparoscopy? Laparoscopy is you make a small slit and through that you do it. It is not a blind needle. Indications are failed percutaneous biopsy, chronic anticoagulation state or coagulopathy, morbid obesity, solitary kidney, multiple bilateral kidney cysts, kidney arterial aneurysm, uncontrolled hypertension. Where all it has been contraindicated, they might be relative indications in the laparoscopic biopsy. And what is the procedure like? Done under general anesthesia, decubitus position, 10 millimeter laparoscopic port. And it is done in the lower pole, minimal retroperitoneal dissection should be there. Laparoscopic cup is used for biopsy and the forceps. And multiple cortical biopsy should be done. There should not be any fulguration, means damaging. It should not be there. So these are the, under the other biopsy, I am seeing the laparoscopy. First is the needle biopsy. Now, I told you earlier that there were some black dots or dark dots, and here also there are arrows. These indicate congestion. After all, congestion means blood. Where does the blood come from? Tuft of capillaries. That is the glomerulus. So, with the naked eye itself, the nephrologist or the pathologist are able to identify that there are adequate number of glomeruli in the biopsy. That having been said, see what is happening over here. So this is the first core, this is the second core, there might be a third core biopsy. They are dividing the ends of it, maybe about 1 centimeter over here for electron microscopy. And another end is being divided for electron microscopy, two ends. Probably they do not want to avoid any pathology. And they take for immunofluorescence one distal end or one end of it, and for the other one they take the more proximal or probably the subproximal end. Similarly, for light microscopy also there is a variation. So obviously it is something similar to your differential count that you are doing. They do not want to miss anything anywhere. Multiple biopsies should be there, multiple cores should be there, division should be there, they should be properly assigned so that the pathology is not missed. Dividing the tissue. One school says do it blindly. And for light microscopy, we'll have to allot the largest. Immunofluorescence at least 3 to 4 millimeters. Electron microscopy 1 millimeter. And there can be a variation in the course. That is what your people are seeing over here. The principle of it kindly understand. Thanks, Wikipedia. Contraindications. This is again a beautiful list compared to the earlier one. So we are supposed to by heart this. Small kidneys. Inability to provide informed consent. Multiple bilateral cysts. Uncorrectable bleeding. Uncontrolled hypertension. Severe urinary tract infection, pyelonephritis. Horseshoe kidney. Horseshoe kidney literally means the patient is having a single functional kidney, which has been united together to form the horseshoe. Uncooperative patient. This is a superb one. Even the earlier one, it will be including all the conditions. So either of this, you people will have to buy. What are the advantages and the disadvantages of a laparoscopic biopsy? Laparoscopic biopsy, it is an outdoor procedure. It can be done under vision. Still, it is better for the patient to be admitted for observation. Wound infection is less when compared to that of the open kidney biopsy. Adequate homeostasis and safe and reliable. If required, prompt conversion to open procedure can be made. All these are advantages of the laparoscopic biopsy. And today, this is becoming the rule. Whenever there are advantages, there will be disadvantages. Costly procedure. Earlier one was something like an FNAC. You do it. Requires a general anesthesia and it is more invasive than a closed percutaneous biopsy. Look at the beautiful words. I would like you people to apply all this. My God, what is this one? Trans-jugular kidney biopsy. So it is through the jugular vein, inferior vena cava, jugular vein. Liver biopsies were originally taken for very sick patients. And then later on, they realized that the same thing could be adapted for the renal biopsy. So it has been done. And in some cases, both liver and renal biopsy are being done by the transjugular kidney biopsy. Low morbidity. Hemorrhage is a complication. Transjugular kidney biopsy is done and simultaneously it can be done for both. And in this case, the right side is preferred. Usually the left side lower pole is preferred. In this case, the right side is preferred. The advantage is safer as the needle passes into a vein away from the major blood vessels. Any bleed directs to the vein, so it is not bleeding outside. Capsular perforation managed with effective coil embolization. This is again one secret. What do? Whenever there is a crack in a wall, you try to plaster it. What these people, the radiologists, do is they have got a coil. They just release it by means of a gun. It goes and gets caught at the site of bleeding. After which there is a thrombus or a clot that is forming equal to the cementing of the walls by you. It is a beautiful technique that has saved many a patient with even cerebral aneurysm, including my mother. The following are the disadvantages. Arterial and calyceal bleeding. And look at this. Somewhere from the top, it is reaching down. I'm able to see the multiple blood vessels. Of course, the shadow of the kidney is seen. A transjugular at the lower pole again. Great. Adequacy and the post-biopsy care. There is always called as post-biopsy care. Even a simple procedure. When you do an FNAC also, you ask the patient to sit down, make them comfortable, and then get up. Otherwise, they'll be going into a postural hypotension and collapsing in front of you. Whereas here, vitals are checked. It can be an outpatient procedure. See, bed rest has to be advised for at least 8 to 10 hours. And it can be preferably an inpatient procedure. Complications can be addressed to. They should be looked out for. Pain, bleeding, perinephric hematoma, arteriovenous fistula. So these are some of the post-biopsy cares we should have in mind, after which we shall go to. So look at the entire chain of events that is over there. Patient is being admitted, biopsy is being performed, post-biopsy patient is being taken care of, after which they are going to the adequacy of the tissue sampling. At least so many cylinders are needed, and this has to be the thickness of it. The needle gauge, there are several ones. 18 gauge is okay. 25 gauge will be little too much, but then this can be an ultimate dictum. For glomerular lesions, at least 5. tubulointerstitial 6 to 10, transplant 7. In general, if you people say about 8, you are safe. You are correct. Clinical information and transportation. So there should always be adequate clinical information, particularly in this. One cannot feed in garbage and get out fruit juice. That is what is happening. We have the material with us and then we try to give a diagnosis. The fruit juice is expected by the clinician and is feeding us with garbage. The specimen must be handled gently when removed from the needle. See, it should not be crushed by a forceps. It is extremely precious, no crush artifact whatsoever. And they say that the 18G needle is used, a wooden stick is used for gently removing it from the needle. The specimen is washed off the needle with saline. Under the dissecting microscope, as I showed you people earlier, the glomerular contents are seen to divide the tissue and rule out any fat, skeletal muscle, or non-renal tissue. A wonderful checklist. This is extremely good. And for electron microscopy, I showed you earlier, the ends can be chosen. Glutaraldehyde can be a fixative. Sometimes even formalin fixed is being advised. Light microscopy, immunofluorescence are the other ones I have already told you. And this is just to depict what is the care that is being taken. A strict aseptic procedure and what is all required over here and the way they are handling it as though it is an in-theater procedure. Sectioning and fixation. Under light microscopy, you people can look for the cellular details. Methenamine silver, there are some special stains which are needed. One will be methenamine silver, two will be peroxide, periodic acid, PAS. These two are mandatory. Serial sections might be needed so that we do not miss any pathology. Fixation has to be prompt and good. 10% buffered formalin is fine for light microscopy. Immunohistochemistry is again something that we people should have in mind. We can retrieve it later on even from a paraffin block. The other fixatives are Zenkas. And in this, there can be a better preservation of the morphology. This is something new. I am not very much aware. Bowen's fixative is also being recommended. No 2 or 3. You need not know everything. At least a Bowen's fixative, Zenka's fixative. 10% formalin, you people should not forget. And silver methenamine and PAS. These are the rules. And there is something called as adjuvant studies. You people also can do molecular studies, in situ hybridization, in immunohistochemistry. So these should be provided room for. So as a backup, I should know at least where to refer, how to shift, what am I supposed to give. These are the list of stains. Kindly buy. Kindly buy. There is nothing. The applications are given over here. Congo red for amyloid, one cosa for calcification. And this is for the cell number basement membrane. Meson spectrum again for the matrix. HNE for the cellular features. Acid fusion, orange, and Sirius red. They are done for immune complex, and Sirius red is done for fibrosis. And thanks to Durgesh for this wonderful picture. It is actually a liver in which the fibrosis has been detected by Sirius red. We pathologists are colorblind. We know only 2 colors, hematoxylin and eosin. And of course, the next is colorless. But then look at the play of colors in this. I hope you people are able to identify the stain. If not, find out. But what I'm interested in this is there are some inclusions found in some cells which happens to be cytomegalovirus identified by acid fuchsin orange. So amazing. And this is what I have been saying about the This is a continuation of the previous table, and I'm showing the slide Sirius red in a renal biopsy. It is supposed to depict the fibrous tissue, which I am finding it as red. Also, this picture, I do not know much about it, but then it is supposed to be a computer image analysis. So have in mind that there is going to be a computer analysis also. And today we are in a world of telepathology where pictures can be sent all over the world. And to my knowledge, pathologists are colorblind. They know only hematoxylin and eosin. Look at the play of colors over here. I hope you people can identify the stain over here. Whatever it is, there is something that is different over. I find that there is an orange color, acid juxin orange, which is used for the intracellular ballooned out cytomegalovirus. So look at the amazing things that are possible. Still, I have not gone into the pathology of it. These are only the technical aspects of it. And these are two of my references. These two, this is one and this is another. There are lots of these, but these two articles I found of extreme use in the mechanism as well as in the interpretation. The interpretation will be following, and I hope that you people don't ignore your own potential. You have got a tremendous potential, students. You've got a much better memory than me, and you'll simply rattle off. Only mistake that you're doing is you don't repeat. Repetition is the mother of knowledge. Do not repeat the number of years or attempts. Repeat the number of times of reading. Apply this in part. Thank you.